Hello, this is Desiree Chappell. It's Tuesday. Welcome to the Roundtable, where we have in-depth conversation with the experts as well as those on the front lines of perioperative care.
Top bed talk.
I'm joined this morning by Dr. Vijaya Gottumukkala, cardiac anesthesiologist from MD Anderson and on the board of directors for the American Society for Enhanced Recovery, and Dr. George Nassif, colorectal surgeon from the Florida Hospital Center for Colorectal Surgery. Gentlemen, thank you so much for joining us today.
Thank you.
Yeah, this is exciting. Did you enjoy the first session this morning?
Absolutely.
Yeah, it's very easy to become energized,
yes.
right? Listening, talking about the shared decision making and points like that. Well, we're going to dive right into some of the questions that I had for you guys specifically. Both of you have become leaders within your organizations for enhanced recovery initiatives and efforts. And I've kind of talked to both of you individually about that. So I want to be able to talk about how enhanced recovery has changed your personal practice and then how you've seen it change facility practices at your different institutions. So,
Sure.
Dr. Nassif, would you like to start?
Sure. I think one of the main things are when we went on this journey to start this process, it was simple ERAS. And I think that for us, as we see here today, it has become, it has gained energy on its own. It has become more of a concept. Now we're doing the evidence base, and it's become a passion, not only for us as the leaders, physicians, but our team around the hospital and the healthcare workers, including nurses, administration now. And really what it has come was an idea to enhance medical care, length of stay and the easy metrics. But more so what we've learned personally is that the patient outcomes, the patient satisfaction, and the quality of care we're delivering now, because of the passion we have and moving and progressing every day with it, has been amazing. And it's seen around all levels that what we do and in constantly trying to innovate and do more, we are seeing this with the outcomes of the patients.
Yeah, I think that whenever people first start, there's so much data on length of stay, costs and things like that. What people kind of forget about when you first start is there's so much more to look at.
Yeah.
And we call them process measures. Dr. Gottumukkala, can you kind of speak to that? What's been your journey and what have you found?
Yeah. So we started this in 2013 with a program in liver, separate from colorectal. But since then, we've expanded to 12 service lines within the surgical practice. In addition, we also started an enhanced recovery in medical oncology, stem cell transplantation as well, coming from a cancer hospital. But knowing that the patient needs after major cavity surgery is different than stem cell transplant or medical oncology, but you still can use the same principles, which are patient-centric, team-based care, trying to improve patient outcomes in a more quantifiable manner. Our journey has been rapid. So once we see how our collective effort improves patient outcomes, everybody gets energized. So we had a mission creep.
Yeah,
so suddenly,
that's a great way to say that, right?
Yeah, within a year, we had 8 programs, and now within 4 or 5 years, we have 14 programs. So over the course of this journey, we've learned quite a bit. And the key points which we've learned is, while the energy and enthusiasm is good, for us to make it a sustainable program, how do you lay the foundation that you can keep moving forward as a continuous quality improvement project? How do you make sure the teams are adequately supported in terms of the resources they need, in terms of the executive support, champion? So based on what we've done so far, now we've created an enhanced recovery charter. So anybody who comes to us and say we want to start a new program, so we show them the charter and help them develop their program. So it's them developing their program, but we are helping them by creating a sort of a framework so you can sustain it.
It's great to have that grassroots enthusiasm and energy, but as that starts to take off, if you don't have that top-down support, which so many people have, kind of building that financial case for your C-suite people and building that structure, kind of that outside platform structure, that you're never going to, you can never sustain this. And it's much, and every time you go into a new service line, it's more difficult each time.
Yeah.
You know.
Yeah.
So, Dr. Nassif, have you had experience in this?
Yes, I do have one comment there, and I think I agree with Vijay 100%. But that being said, what I've learned is that when you set up these protocols and when you set it up and everybody's in line, that you have to be fluid. And what I mean by that is, unfortunately, a lot of the times the people on the ground or your champions are there to stay, but the parts around you move. And that can come from in the C-suites and administration, and so people who are involved have moved on, have gone somewhere else. So I've learned to be somewhat patient, because you can continue the ground level, but you need to keep re-educating, re-upping the stakes for people, showing everybody. So it's a constant learning and it's a constant progression throughout this. It doesn't just get set up once and then you're on autopilot. You have to constantly be on your toes, and you have to constantly work at it. And I think that is very key.
Yeah, I always say that's what you have to build into that structure.
Correct.
That's like one of the components that we often forget. We don't have a ton of time, but just to take the last couple of minutes here, because I know this is something that both of you are passionate about, but also a hot topic here in the U.S. is the opioid epidemic, and how enhanced recovery is being used to address the opioid epidemic in our surgical population. We know that up to 1 in 10 people can become addicted after their surgical experience. So, what are you guys seeing as enhanced recovery's role in this? And then we're going to take it one step further to look specifically at cancer patients, because I think chronic pain patients and cancer patients are maybe we need to look at them a different way. So what is your experience, Dr. Nassif?
So first off, like you said, I can give you much more of the acute patient being a surgeon. So we have found almost by accident, when we started our program, we had some issues with narcotics and the inability to get a PCA pump, for instance. And that set off a snowball or a domino effect that we didn't have it, so we had to find alternatives. And each time we would find an alternative, whether it's an oral medication that didn't agree with the patient, the next thing you know, a month or two into this, we said, the patients aren't needing narcotics. So standard in our group now, our colorectal group, on all patients, all cancers, all IBD or Crohn's, ulcerative colitis, and diverticular disease, we put everybody through opiate-free total perioperative treatment. Now, obviously that can't go across the whole board for everybody, but we have not only found not giving scripts to go home and, as you say, causing the problem, but most importantly for us, the patients are happy. Yeah. They're happy with their treatment. They say the pain is actually more controlled using multimodal therapies rather than just narcotics with more narcotics and more narcotics. So we've, by accident, found that our outcomes, our patient satisfaction, our length, everything we talk about has improved by removing the narcotics. Now, obviously, as Vijay will attest to, the hardest part of this is the culture of narcotics. Mm-hmm. You have surgery, you are hurt, you need narcotics. To get people, to get nursing, to get everybody over that is a very difficult task. However, when you show outcomes, as you said, it makes a big difference. And I think that this is better for everybody, the patients and society. As you said, there's a big problem. So, well,
I mean, the problem is pain. Pain is the fifth vital sign now, right? I mean, that it's when we started that, it changed the whole concept framework of how we address pain, which is now kind of leading to where we are right now with this opioid epidemic. Dr. Gottumukkala, can you speak specifically towards, taking care of those cancer patients and those that, are chronically on opioids for pain? How are you treating those patients? Because can you do opioid sparing techniques or non-opioid techniques for these patients?
So that's a very good question, because then that distinguishes opioid naive patients coming for acute surgical care, whatever the procedure might be, from a patient who's on chronic opioid therapy. For us at MD Anderson, what we're doing is, if a patient comes for surgery who's already been on chronic opioid therapy, we refer them to our chronic pain docs. And they do a thorough evaluation of why they're on chronic opioids, for how long have they been. Is there a behavioral component to their chronic opioid use? And based on that, is there a reasonable way to minimize opioid use post-discharge? During the acute phase of care, all of us do multimodal opioid sparing strategies, but these patients do need their maintenance opioid dose. Yeah. And this is not the time we need to cut down on their maintenance opioid dose. So we do give them the maintenance opioid dose, but we also use multimodal strategies, and we see how best we can get them in the post-discharge phase, at least at their maintenance dose, if not lower. Yeah. But our goal is try not to escalate their chronic opioid use to a much higher level.
Have you noticed a difference in the post-op treatment of these patients? Are we taking a better look at how we're managing them for their chronic pain? If they received multimodal analgesia during their surgery, are we taking a look, is that applicable, post-operatively in the long term? Can we manage these patients in a more multimodal way than just, kind of chronic opioid usage? Yeah. Do you think? Have you seen a difference?
That is the discussion we need to have move forward, and we need to bring in our chronic in each of our own practices. We need to engage our chronic pain docs. For an MD Anderson, we are fortunate enough to have palliative care, rehab medicine, and integrative medicine folks. In the high-risk patient population, we get them involved early in the perioperative continuum. Yeah, this is a work in progress, and over time, with data, we'll need to see if we can utilize the same strategies for these patients on chronic opioid therapy. But yeah, it's a completely different patient population.
Yeah.
And we need, again, just like the multimodal opioid sparing strategies, which need to be procedure and patient specific.
Right.
Even our ways at minimizing perioperative use has to be classified into opioid naive patients and patients on chronic opioid therapies, and how do we effectively manage them.
Yeah.
But I think I would always put the patient first. Mm-hmm. We have to do everything we do to get them back to their baseline, but we have to tailor these approaches to the specific patient needs. I think we shouldn't forget that.
Yeah.
And one of the pokies was on opioid therapy, and I liked very much the conclusion of that was, how do we optimize pain control by minimizing opioids and minimizing adverse effects? Mm-hmm. So I think over a period of time, we'll be looking at the non-opioid adjuncts and see if they're providing the benefit with minimal to no increase in adverse events related to those drugs.
Yeah. Gentlemen, it's been a great conversation. I could talk to both of you all day long. We're going to wrap it up for this session. Please join us again here for another roundtable discussion. Thank you so much. Enjoy the conference.
Top Med Talk. Top Med Talk.
Thanks for listening. Be sure to follow us on social media, Twitter, LinkedIn, and Facebook, and subscribe to our newsletter, where Monty and I give you highlights from the previous week. Also, check out our calendar for the next Top Med Talk event. You've been listening to the Roundtable on Top Med Talk. Have a great day.